Larry Nightstein, Los Angeles. On the under 26 that are going on parental plans, it's like the glass half full and empty. It's great that there are 3 million between 10 and 11 that got on their parents' plan, but between sort of January of 12 and January 13, it's been sort of a flat line and even maybe a slight decrease. So I'm wondering about your thoughts about, have we hit the limit? Are there other ways to help? And then on the exchange systems, do you have any idea about the cost of parents versus parents and a young adult? How cost effective will it be? What impact of adding that young adult to the, and so they could be covered because they're covered under their parents' plan?
That's a really good question, or questions, and I don't have a complete answer. And part of the reason I don't have a complete answer is that the premium costs for different plans vary dramatically between companies in different states, and depending on whether there's coverage for a single employed individual or family coverage that includes all children, or whether it's employed individual plus spouse. So it's really hard for me to know the answer to what the comparative costs will be. I think that in many instances the costs will still be less on a family plan than on an individual plan, but that really could vary depending on the state and depending on what individual health insurance companies decide to offer and how badly they want the young adult population to enroll.
Parents may choose not to spend any of that.
And parents may choose not to spend any of that, and I think that's some of what we're seeing with the sort of flatlining. You know, there was a group of people who were very anxious to get their young people onto their plan, and then others who either didn't have access to affordable coverage, even though their kids might be eligible to stay on their plan. They just couldn't afford to maintain that coverage for their young people.
Thank you.
So Larry, there was an interesting webinar about 3 months ago on young adult coverage, sponsored by the group at Rutgers, funded by RWJ, that looked at who came on and who didn't come on. And their comments were that many individuals who came in on that first wave were young adults who were in relatively bad jobs, who decided to go back to graduate school to further their degrees and so forth, and kind of switched onto the parent plans. And so all of a sudden we saw this rapid increase in, they were kind of waiting for this almost, and that may account for some of the, I didn't realize there were that many people wanting to go to graduate school, but whether that is what that high increase was in the first year. I don't know.
And another factor may be that some companies are starting to not offer family insurance coverage simultaneously to this trend. So disaggregating that would be very important as part of an analysis. Mary Ann?
Just a comment that'd be interested in your question or your response to that sort of integrates both of these two topics. When I work with international groups on what they call youth mental health, which they largely talk about as being 13 to 25 or 30, so going across the child and into the adult world, first of all, their first comment to me is, your healthcare system is crazy, mostly referring to the healthcare financing, how we finance our healthcare coverage. But then these countries that have universal healthcare coverage go on to describe the exact same issues that we have in the split between the child and the adult healthcare provision system that you very more than adequately, very lovely description of the complexities of that. So that it's partly, we know that healthcare coverage is essential, but it's not enough. That we need to be able to pay for the services, but that doesn't change the problem of people not being trained in how to work with this population, providers who are willing to offer specialized services to them, and trying to figure out how to handshake between the child and the adult system around young adults. So more of your thoughts on sort of the complexity of we need the healthcare coverage, and yet that really doesn't get at many of the sort of the leadership training and other issues that keep our system split into child and adult that does not benefit the young adult population.
It's a great comment. I'm not really I don't really have an answer for it. I know within our own system, that's why 2 years ago we changed the name of our division in clinical services to adolescent and young adult services, because we felt that there was no place for young adults to go, that our individuals who were training in adolescent medicine needed training in how to take care of young adults. Our pediatricians needed to understand what the consequences were from what happens during childhood and how you make that transition to young adult. But it becomes a real problem. I mean, I used to think it was perhaps easier to take care of young adults. I would say I think it's a bit more complicated because of the barriers between working with their families or the systems that they come from, and disclosure and all of these things that I really respect the issue of privacy and confidentiality, but I think it's incredibly complicated, and I don't have an answer other than we need to be training and working in health professional schools and graduate schools to really bring this population and the needs of this population into our training programs, and perhaps that will make a difference. I think we need to also inform our consumer, which is our young adults, on what they should be expecting when they see clinicians on, this whole movement towards patient-centered care in this country. We need to really advise the consumer on what he or she should be expecting when he or she comes into a system of care. Like the pharmaceutical company markets to the consumer, we need to market to the young adult. What should you expect when you see your primary care physician or you get referred to a mental health specialist or whatever?
Thank you.
Trina, we'll have you as our last question.
Okay, thank you. I'm Trina Anglin. I originally was going to ask Charlie his thoughts about training. However, I think that that has already been addressed. So I have actually sort of a technical question to Abigail. And I remember a while ago that EPSDT benefits, for children on Medicaid were supposed to be extended up through the ages until age 21. And I have no idea anymore whether or not that really took place. But if it did, then how would that interact then with the benefits that would then be available to basically all people, for preventive health services? Because, for people who don't know what EPSDT is, it stands for Early Periodic Screening, Diagnosis, and Treatment, and that the idea is for children on Medicaid is that it really provides the gateway, like once a provider identifies an issue, then Medicaid has to pay for the full assessment and for the treatment. And in contrast, that adults on Medicaid historically did not necessarily have that kind of entree into treatment. So I'm just wondering what your thoughts are on the possible intersection.
I think that's a really good question, and EPSDT was often referred to as the gold standard because it did require both a comprehensive health assessment of all Medicaid-eligible children and adolescents and young adults, really up to age 21. And for a very long time, that gold standard was honored in the breach, and the comprehensive health assessments were not happening at the rates they should have, and thus the follow-up diagnosis and treatment wasn't necessarily happening either. That EPSDT standard remains in effect, and actually the screening rates, the assessment rates have gone up significantly in recent years. So that's been as a result of a lot of very hard work on the part of a lot of advocates and healthcare professionals and agency personnel. There is a big gap now between what is required under EPSDT for children, adolescents, and young adults up to age 21 who are the sort of traditionally eligible Medicaid population versus the newly eligible. Young people in the young adult age group who are added to the Medicaid rolls as a result of a Medicaid expansion even if they're in that 19, 20-year-old age group, will not necessarily receive EPSDT benefits. So that's a group that will fall through the cracks. In addition, as I mentioned, in the private insurance arena, the cost sharing, the no cost sharing preventive services really only covers the preventive services and not the follow-up diagnosis and treatment. So we've taken some steps toward expanding that gold standard to a broader segment of the population, but we have a long way to go for that to even be the standard. So I think that was really a great question, and it's something we should be looking at as the implementation rolls out.
There's also just one comment I'd like to make. You really talked about the kind of free preventative services and no cost sharing. The reality is what's happened in the state of California, that the only cost sharing that's occurred now is on the part of the providers, because the insurance companies are essentially paying us exactly what we got over the previous years. So our patients don't have to pay their $5, $10, $20, or $40 copay, and the providers do not get reimbursed anymore. So some of the cutbacks in what doctors are now willing to do, I think, is going to unfold. That, for an example, would be treating acne or something that's rather kind of common in preventative services. We would consider preventative services. Clinicians are saying, no, that's a follow-up visit because that's a copay. So I'm not going to cover acne when a young person comes in for his general or her general checkup. So I think it's kind of a catch-22, all of these provisions.
I think that's a really, really good point, and I think it illustrates the old proviso that the devil is in the details. I mean, you can see this sort of banner headline of no cost sharing for preventive services, and then you start reading the fine print, and it's yes, but the providers aren't paid as much. Yes, but diagnosis and treatment may not be included. Yes, but. And so they're just at every step along the way. And I'm not trying to be a glass half empty person here. I think the glass really is half full. It's just that at every step along the way, we must look at the fine print. And I wanted to just make a quick comment to the question prior to Trina Anglin's, which is that I think that we need to not only do outreach to young people to make sure that they enroll, whether it be in Medicaid or in, a private health insurance plan. We need to do outreach to young people to make sure then that they know where can they go for care, who will accept this health insurance that they have, what kinds of services, as Charlie was saying, can they expect to get when they're there. And so there needs to be sort of outreach in a much broader way than just getting them onto a health policy, whether it be Medicaid or a private health policy. And I think that is not something that's been done much at all, even for the adult population, but particularly for this young adult age group. And that's where the social media strategies that were talked about in the previous session can become extremely useful, because this is a population that can be reached in that way, unlike us 20th century.
So on that pragmatic and hopeful note, I just want to thank our speakers and close the session.